Hello, we are now going to do Lab 4, which involves both cardiovascular physiology as well as blood vessel anatomy. Now, the exercise go from 22.1 to 22.9, as well as 23.1 to 23.4. The latter part includes hands-on lab assessments or exercises where you would use a stethoscope as well as a sphygmomanometer. Since we're not doing this in a lab situation, what I recommend is that you really review the videos that I have provided for you to give you some of the basics about what and how these tools are necessary to monitor things like heart rate, respiration, as well as blood pressure and pulse. Okay? In the meantime, let's get ahead. There is a lot of material that we need to cover. First off, you're to review the blood vessel anatomy and slides, as well as the gross anatomy of the arteries and veins. I've provided videos that will review the models of these. Any microscopy slides, I would encourage you to also review the images that are in the lab exercise sections. You are to review the cardiovascular physiology using the stethoscope, examining heart rate, blood pressure, and pulse. The videos should be able to provide you with sufficient information as well as this video. Examine the effects of exercise on blood pressure and pulse rate. That is going to be dropped because of the fact that's normally a lab that's done in a classroom, especially with individuals that will monitor their partners. So if an individual gets weak or ill or something else like that, basically nobody has a hazard. Now, there are two worksheets. One of them is basically pages 413 to 416, and all I'm asking you to do is to do page 431. Wherever they refer to lab exercises that involve what you studied, you may pass on them, but do try to take some time to review 431 and some of the basic principles involving stethoscope, pulse, heart rate, blood pressure, sphygmomanometer, as well as pulse. The microscopic structure of blood vessels. First, let's talk about arteries. Now, blood vessel walls have three distinct layers that are referred to as tunics. The tunica intima, the tunica media, and the tunica externa. The tunica interna is the innermost layer. It is simple squamous epithelium, otherwise referred to as endothelium, that lines the lumen, the inner space, and has a basal membrane and a thin layer of loose connective tissue. The tunica media is the middle and usually the most thickest layer. It is composed of smooth muscle and elastic fibers. The tunica externa, it also goes by the name tunica adventitia, is the outermost layer composed of connective tissue with numerous elastic and collagen fibers, and it is continuous with the connective tissue of adjacent structures. There are three types of arteries: elastic, muscular, and arterioles. Elastic, these usually include the great arteries, the aorta and the pulmonary trunk, and some primary branches. They have the largest luminal diameters. The walls are relatively thin. They have lots of elastic fibers to handle the pressure fluxes that occur. The muscular arteries deliver blood to specific body regions. They have the thickest walls of all blood vessels. In the tunica media, it is mostly smooth muscles with very few elastic fibers. The arterioles are the smallest arteries and deliver blood to capillary beds. The walls are thin, but contain all three tunicas. The smallest contain only endothelial and a single layer of smooth muscle fibers. So as you can see in this diagram here you have the tunica interna. Underneath the endothelial cells, you'll have a basement membrane. Then you have sort of this internal elastic lamina and basically an external elastic lamina. Sandwiched between it is basically smooth muscles. This makes up the tunica media. Then you come up with the tunica externa, which is more or less more connective tissue and just to basically cover and contain the arteries. Now, I want you to be mindful that there's going to be a great difference between the arteries and veins. The arteries, as you can see, the tunica intima, otherwise known as tunica interna, the tunica externa, otherwise known as tunica adventitia, and the tunica media. Okay? But when you take a look and compare artery with vein, you will find several differences. Yes, you still have the tunica intima, tunica media, and tunica externa. What you find as a major difference is the thickness, thereby the amount of tunica media smooth muscles. It's a lot more here in the artery, and it's a lot less in the vein. The other thing that you will find in a lot of ways is the lumen. The lumen is much larger, and that's why the veins usually hold up what is called the blood reservoir. But when it comes to shifting blood flow and to a point blood pressure, it is the tunica media in the arteries that really play a critical role in this. Now, activities of smooth muscle and tunica media in the arteries and arterioles are influenced by sympathetic nerve fibers and various hormones, such as norepinephrine, epinephrine. Vasoconstriction is when smooth muscles contract and the lumen walls decrease and the blood pressure increases. Vasodilation is when smooth muscle fibers relax and the lumen diameter increases and the blood pressure decreases. Okay? Peripheral resistance is defined as the resistance to blood flow in arterioles. The greater the peripheral resistance means the increase in blood pressure, as you can see here. This is a very nice comparison for a diagram between the various layers of the artery, as well as the lumen of the artery, the various layers of the vein, and the lumen of the vein. Notice also the presence of valves there to prevent backflow. And then you have this nice comparison here at the capillary end, where basically it's very simple. It's basically a basement membrane and one layer of endothelial cells. That's so that you can have the diffusion of water, nutrients, dissolved gases, ions, etc., whereas still retaining red blood cells and much larger proteins inside of the capillary. Note also the presence of vasovasorum in the tunica externa area, and this is to supply blood and nutrients for the actual more responsive tissues such as the smooth muscles here and here. Now, keep in mind when I talk about vasoconstrictor versus vasodilator, and this can occur not only because of sympathetic muscle activity, but it can occur via drugs, various medications, etc. Vasoconstriction, you have a reduction in lumen as compared to the normal blood vessel diameter, the lumen diameter. And then you have the vasodilation, which is a vast increase in the lumen, and hence you would have less resistance and a lower blood pressure. Now, in the microscopic structure of blood vessels, veins and capillaries, veins have all three layers, tunicas as arteries, as I mentioned. Veins also have valves to prevent backflow of blood and are more common where venous flows against gravity, such as in the lower limbs. Valves are continuous with the tunica intima and are similar to cardiac semilunar valves. Varicose veins, these are the bulging of the veins and the pooling of venous blood, usually caused due to genetics, pregnancy, abdominal tumors, obesity, and excessive standing. Here we have the artery, here we have the smooth muscles, we have a vein, and we have, of course, the capillary. But here's the point I want you to keep in mind. If you have consistent pressure out here, this is going to cause the expansion, the stretching out of these veins, which is what accounts for varicose veins. Here you have a nice cross section here, and what you have is an artery. Here's another artery, a much larger one. Notice the thickness of the tunica media, and a little bit of space right here is where you're going to have the tunica intima and the tunica adventitia. Notice how that differs with the tunica adventitia, as well as the thickness of the tunica media. There's a thin lining there, the tunica intima. Notice the artery lumen and the expansive vein lumen, okay? Now, when we look at blood vessels, we have to keep in mind such structures as the veins, and this is where you get the skeletal muscle pumps, where you contract the legs, contract the muscles. That's going to cause squeezing at the lower end of that before you get to the valve, pushing the blood, or assisting in the pushing of the blood against gravity, and as a backflow attempts, the valve closes, okay? Now, it's interesting also to note an important vein as we're looking here, and that is the great saphenous vein, which a lot of times a piece of it is cropped out and used for coronary bypass, okay? In the capillary, there are several different types of capillaries. Capillaries are the smallest blood vessel. They're the site of blood tissue exchanges of nutrient and waste, and the types depend on differences in permeability. Continuous capillary is least permeable as an endothelial lining that is uninterrupted. Some cells are held together also by tight junctions. Fenestrated capillaries are more permeable than continuous. The endothelial cells contain pores, that is fenestra, that are covered by a thin basal lamina. Now, the most permeable, all three types, is the sinusoids. Endothelial lining they have, but it's highly irregular and loosely arranged, and many pores and even spaces between cells exist. So this is where you would get the greatest amount of exchange, and larger molecules and variety of other substances can pass from one side to the other. When we talk about microcirculation, this is the circulation in the smallest of the blood vessels. So you can see this comparison here. The endothelial cells here, notice that there's no gaps between the cells. You have a slight cleft here, but you also have a continuous basement membrane. When you get here, you have fenestrations. They're kind of thinning out, opening little spaces. You still have a basement membrane. But move over to here. You have intercellular gaps. You also have an incomplete basement membrane, literally allowing products to move from the lumen out here. And what I mean by products is, if that gap is big enough, you could have large molecules, proteins. But that doesn't just mean that they would leak out. That could be a means in which they can enter. Now, when we look at pressure types, you need to get this reviewed. When you talk about pressure from one side, the arterial, going across this, shall we say, bridge, the capillary, and leaving the veinule, you're going to notice differences in pressure. Keep in mind that blood is not merely just water. It is not merely just plasma, but it has large formed elements, white blood cells, red blood cells, and then of course you have thrombocytes, platelets. So on this side, you're going to have the greatest amount of pressure. So you have the capillary hydrostatic pressure, CHP, pushing out, and you have some resistance, which is due to the blood colloid osmotic pressure. And then you have the net difference, which is the net filtration pressure. That's the difference between CHP and BCOP. Here, at this earlier part, closer to the arteriole, distal to the venule, you have the greatest amount of pressure. CHP is greater than BCOP, so fluid is forced out of the capillary. Farther down the length of the capillary, you have an equalization because you've lost some of the pressure, because you've lost some of the fluid as it's left, gone into the tissues, okay? Now, what happens is that as time goes on, or I should say we travel down further the length, the net filtration pressure is now negative, which means more can enter back into the capillary because the BCOP is greater than the CHP. Now, this is fluid movement. So nearer the venule, reabsorption will predominate. Nearer the arteriole, filtration predominates. And so you have a certain amount of fluid that comes out, fluid that goes back in, but notice the numbers are not equal. 24 liters, 24 liters, but when you get back here, it's 20.4? Yes, because you have 3.6 liters per day flowing. And where does it go? Well, you don't want it to stay there, otherwise it would be edema. So it returns via the lymphatic vessels, which we've talked about in a prior chapter. Blood vessels in the pulmonary circulation. Circulation is driven by the right side of the heart, delivers oxygenated blood to the lungs for gas exchange and return of oxygenated blood to the heart. You need to go over these principles that we've dealt with in the previous lab as well. Right, left pulmonary arteries, branches of the pulmonary arteries, pulmonary capillaries, and gas exchange occurs between the capillaries and the alveoli. These are the air sacs. The pulmonary veins eventually move into the blood flowing into the pulmonary veins from venules. Then you have to keep in mind of two very, very important things. One, pulmonary embolism. This is a blood clot that blocks the branch of the pulmonary artery. Now, by the way, the embolism does not always have to be blood clot. It can be a fat globule, such as from a leakage of marrow. It can be an air bubble, such as somebody who did a sloppy job of doing an intravenous injection and didn't tap out of the IV syringe all the air bubbles. Now, deep vein thromboses, this is a blood clot that forms in the body, usually in the lower limb. This is when a blood clot will form. Sometimes it's because of literally low circulation, low movement, and that can happen sometimes when you have these very long flights going across very many time zones. For example, Australia to Boston, San Francisco back over to New Delhi, India, when you're crossing many, many time zones. And that's why now they tell people that do these long 8, 10, 12, 15-hour flights to get up and move around. Because what happens is that they will sometimes have a DVT, deep vein thrombosis form, and then later on, it may lead to a heart attack if it becomes dislodged and goes to one of the coronary arteries. So we've dealt with a little bit of this circulation here of the pulmonary circuit. You have blood that goes in, gets oxygenated, comes back out. And now what we're going to start doing is moving away from this and going into the systemic circulation. So, blood vessels of the systemic circulation, head and neck. Locate and review following the blood from the heart. Now, some students get really panicky. I'm going to give you a one pointer here. One, I've got a couple of videos that are much more detailed, and the actual instructors spend a sufficient amount of time going over and following models. I encourage you to view those videos. But the other thing you can do is simply just take your book, open it up, and follow a drop of blood from the heart through an area of the systemic circulation, following it artery by artery to arteriole, and then venule to vein, and then back to the heart. That is one of the ways it's going to help you to learn. We start off with the aortic arch as blood leaves, going into the brachiocephalic trunk, the left common carotid artery, the left subclavian artery, and then we have the internal and external carotid artery, the vertebral arteries, and the middle cerebral artery and the anterior cerebral artery, as you can see here, up through here and up through here. I encourage you to take the time to notice how the branching off occurs and to follow some of these extremely important arteries as they supply the neck, the brain, the rest of the head, and the facial area, etc. It is extremely important, and yes, you may be tested on that. Now, let's deal with blood vessels of the systemic circulation, focusing again on the head, but this time we're going to be dealing with bringing blood back to the heart. So, right and left brachiocephalic vein, superior vena cava, subclavian vein, dural sinuses, internal, external jugular veins, and vertebral veins. As you can see here, the blood comes around through these dural sinuses, meets at a confluence of the sinuses, drains into the jugular foramen, and you also have an entry here by the vertebral vein. On the exterior, now you notice that there's a slight coloration difference. You have the external and the internal jugular, okay? Here, the jugular foramen follows down, all right? Here, you have what supplies blood to the facial area, and this empties into the internal jugular, as does through the jugular foramen, and you have this large vein taking all this blood, all right? So you've got the external, which empties right in to the right subclavian, and you have the blood following the internal jugular. This is the external jugular, and they all meet together and follow down the right subclavian vein, and of course you've got the opposite on the other side, the left subclavian. This is following down the superior vena cava, okay? Yes, you need to know temporal, maxillary, facial, occipital, as well as the jugulars, both of them. Now, when we talk about the cerebral arteries, we're going to be talking now about the circulation to the brain. Anterior posterior cerebral artery, basilar artery, middle cerebral artery, and there is a cerebral arterial circle called the circle of Willis. This also surrounds the optic chiasm and pituitary gland. And then we have the anterior and posterior communicating artery. So here is the circle of Willis, okay? You'll notice that you have the vertebral artery coming up. You also have this cerebellar blood flow here. You have the basilar here, the posterior cerebral, posterior communicating, okay? You've got the internal carotid here. This would be, of course, the other internal carotid. You have blood flow going around here through the anterior communicating, and you also have right here the anterior cerebral. All of this is supplying blood to the brain. Notice the landmarks you have here, the pituitary gland, and you have also the optic chiasm right here, okay? So you want to keep in mind these structures. You want to identify other blood vessels that go into the thoracic cavity. This is where some of these videos are going to be very helpful as they follow models and give you some understanding of where these blood vessels are. The blood is supplied by branches of the thoracic division of the descending aorta. So these will include the bronchial arteries, esophageal arteries, mediastinal arteries, the pericardial arteries, posterior intercostal arteries, superior phrenic arteries. As you can see from here, we start having the descending part of the aorta, and you will have the bronchial, esophageal, mediastinal, and pericardial. These will be branches off of this major artery here. You also have the intercostals. Notice that they're right next to the ribs, and you have the superior phrenic, which supplies blood for the diaphragm. You will notice below that once you pass through that diaphragm, you're going to have a variety of arteries that are going to take care of the abdominal and, to a lesser point, the pelvic cavity. We'll get into that in a bit. Okay? Now, moving forward, we also have to be mindful of the venous support. Now, the zygosystem of veins. This is a variable system that drains blood from most of the thoracic structures. You have the azygos vein, the hemiazygos vein, and the posterior intercostal veins. And you can see them here. Here are the azygos. Here is the hemiazygos. And what are they doing? They're taking blood through the intercostal veins, etc. You have the esophageal, bronchial, and mediastinal veins through here, and it's collecting blood that will eventually come into what will be the superior vena cava, coming down into where the heart would be right there. Notice that you still have that boundary here, and that is the diaphragm, okay? Notice that coming up the blood supply here will be, of course, the inferior vena cava. You have also the internal thoracic here, okay? Now, let's get into the abdominal pelvic cavity. At the level of T12, the descending aorta enters the abdominal pelvic cavity, passing through the aortic opening to the diaphragm. It will consist of 3 unpaired and several paired branches. Keep in mind, unpaired and paired, they're very important. Paired usually are existing because they're feeding organs that exist in part on the left as well as the right, such as the gonads, the kidneys, and the adrenal glands. Unpaired because they stretch out in a large branch pattern to meet up with the needs of the digestive organs, etc. So you have the celiac trunk, superior and inferior mesenteric artery. Also, you have a special arrangement here of the medial sacral artery. So you can see you have the superior mesenteric, the inferior mesenteric here. You have branches of the celiac trunk, which include the left gastric, splenic, and common splenic. Here's the celiac trunk right there. Okay? Now, you have the inferior phrenic, which is right up here, and that's supplying blood to the other side of the diaphragm. You have the branching off for the renal, adrenal, the renal, and would be the gonadal. Then you have this branching off of the common iliac. Okay? Now, here's what it looks like with the organs, and that's why you have this superior mesenteric artery that spreads out. I don't expect you to know each and every one of these minor little branches, but I do expect you to know superior mesenteric artery, inferior mesenteric artery, and the celiac trunk, the gastric artery, etc. Now, you've got the splenic arteries here. You have the left gastric artery. You have the common hepatic artery, which feeds to the liver. Okay? So you've got common hepatic artery, branches of the splenic artery, superior mesenteric artery, inferior mesenteric artery. Now, veins that drain blood from the abdominal pelvic cavity and lower limbs empty into the inferior vena cava. Yeah, we know that. So let's start with the inferior vena cava and walk backwards, going to the common iliac veins, phrenic veins, hepatic veins, adrenal veins, renal veins. Also, we have the gonadal veins, whether it's ovarian or testicular, the lumbar veins, and then we have something else you need to be really on top of, because it's going to help you also when we get into the digestive system, and that is the portal system. The portal system is a modified portion of the systemic circulation in which blood passing through a second capillary bed before it enters the veins that return blood to the heart. What we really have is this. You have a capillary bed in the intestine. Picks up lots of nutrients, monosaccharides, and particularly amino acids, etc. But that doesn't go immediately into the rest of the systemic circulation. It goes first through another capillary bed in the liver, the hepatic. And then it gets transferred over and generalized into the rest of the blood. But we'll get into that more as we move on. So, hepatic portal vein, gastric vein, splenic vein, superior and inferior mesenteric vein. As you can see here we have renal, gonadal, adrenal, and then phrenic veins. And you can see some of the branch work of the hepatics. Notice that it's all adding blood into the inferior vena cava. Don't forget the intercostal veins and the branches of the esophageal, bronchial, and mediastinal veins. Okay? Now, this is with the organs. The basic gist is this. Watch. Blood coming up through here from the intestine. Blood coming back from here from the intestine. Blood coming back up through here. It is all going to head through this portal vein, which gets distributed to the liver, which may pick up the amino acids for protein synthesis, may pick up the glucose for storage, or may release it, and then it comes into the hepatic artery here and empties into the inferior vena cava. Note you have a splenic vein in its branches, right here. You have the inferior mesenteric vein and its branches, right there. And you also have, of course, the superior mesenteric artery here and all of its branches. Notice that they pick up blood and feed this from large intestine, small intestine. Now, the anterior thoracic wall and upper limbs are supplied by blood vessels from the subclavian arteries. So you have subclavian artery, internal thoracic artery, anterior intercostal arteries, axillary artery, brachial artery, deep brachial artery, ulnar and radial artery, as well as the superficial palmar artery and deep palmar artery. Now, here's the point. As you notice, you move from this branch from the brachiocephalic, and you eventually move to the right subclavian. You're going to start going into this branching out that's going to occur. So you have the arteries of the arm, axillary, deep brachial, brachial, ulnar, collateral arteries. What I want you to keep in mind is that you might ask, why is there a deep brachial and a brachial? The reason being is that arterial blood can be redistributed, especially if temperature is low and you want to retain the heat from the blood. You're going to have a countercurrent exchange system where some of that heat will be exchanged from the artery to a parallel vein that will take it back into the body core. You will also have a radial artery going against the radial bone and an ulnar artery going against the ulnar bone. And then you get into the deep palmar and the superficial palmar arch, which of course they have branches off of them of the digital arteries right here. Now, we've got to deal with the venous flow. For the upper limbs, they are drained by veins that empty into the brachiocephalic vein. So this includes, of course, the axillary vein, subclavial vein, brachial vein, radial vein, ulnar vein, internal thoracic vein, anterior intercostal veins, basilar vein, cephalic vein, and medial cubital vein. What do we see here? Let's start at the other side. Let's start at the hand. Superficial palmar arch here, deep palmar arch here. These are the digital veins here. Taking blood flow coming up, we're going to have ulnar. Now, there's something here that you have to keep really mindful of. You see the difference in color? Kind of a light blue, kind of a dark blue. Dark blue is for deep veins. Light blue is for superficial veins. And so you have the superficial flow going up until it meets up with basically the brachial at the axillary point, the joint here. So basilic is superficial. Brachial is deep, okay? And what you have here is somewhat a veins. So you have the cephalic here, medial cubital, right around here at the elbow site. And you bring all of this back together till you get to the right subclavian vein and enter into the brachiocephalic and then down into the superior vena cava. This is extremely important to understand about blood flow. Now, when we identify blood vessels in the lower limbs, we have to deal with the pelvis and the lower limbs. They're being supplied by blood vessels that arise from the common iliac arteries. We have left to right common iliac arteries, external, internal iliac artery, femoral artery, the medial lateral femoral circumflex artery, the deep femoral artery, the popliteal artery, the anterior and posterior tibial artery, and we're getting down toward the foot now, the fibular artery, and the dorsalis pedis artery. So starting up here, you've got the deep femoral, you've got the femoral. You have the descending genicular, you have the popliteal, you have what eventually is the fibular, the posterior tibia, the anterior tibia. We have the dorsal pedis right here, and then the plantar arch right here. Okay? Now, if you turn that around, you will look at the back of the leg, you will see much more clearly you have from the internal iliac, you have the external iliac. These all are branching off from the common iliac. So now you have the right external iliac, the deep femoral. You have these branches off of it of the femoral circumflex, and down here is your femoral artery, all the way down past the popliteal, and branches off with the anterior and the posterior tibial, the fibular, otherwise known as the perineal, and then you get into the arteries of the foot. Okay. Now, when we deal with all of this, we have to also deal with the venous flow coming back. Keep in mind that it's important to have those muscular contractions, because as they contract, they will help flex and push blood up the veins in the lower limbs. So the pelvis and lower limbs are drained by veins that empty into the common iliac veins. And then we move from common iliac to internal external iliac veins, the greater saphenous vein, which supplies a vein graft for coronary bypass surgery. I mentioned that before. We have also flow coming up from femoral vein, popliteal vein, anterior posterior tibial vein, and the fibular vein, which you can see right here. Note, light blue again is superficial, dark blue is deep. So we have the flow coming up from the femoral as well as the deep femoral. On more the surface is the greater saphenous. Okay. We have the posterior tibia, the anterior tibia, and we have the plantar venous arch here, the dorsal venous arch there. You can see some of this if you look on the back end here. You have the femoral here vein. You have the popliteal back here. You have also the greater saphenous up through here. The deep femoral right there. Okay. Anterior, posterior tibial, fibular. Okay. Now, during the cardiac cycle, we're going to move into this for a few minutes now with cardiovascular physiology. The opening and the closing of the heart valves directs the flow from atria to the ventricles and from the ventricles to the great vessels. As a result of closing of these valves, they produce the two distinctive sounds, the lub-dub, that can be heard using a stethoscope. When we look at the cardiac cycle, we will note the atrial systole, ventricular systole. The atrioventricular valves, the AV valves, close and produce the first lub sound. The ventricular ejection and ventricular diastole, the semilunar valves will close and produce the second dub sound. End of the cardiac cycle, the AV valves will open and the ventricular will passively fill up with blood. So you have atrial systole, ventricular systole. And as you finish with the atrial systole, the atrial diastole will continue. Then at a certain point, you're going to have here the ventricular diastole. All of this is occurring in 800 milliseconds. Milli is thousands. So basically, in 0.8 seconds, all of this occurs. Now, if you review the cardiac cycle, atrial systole, atrial diastole, ventricular systole, in the beginning you have just isovolumetric contraction, in other words, building up a pressure but no change in the volume. When you finally achieve enough pressure, you're going to continue with the ventricular systole, but now you have ventricular ejection, blood moving out of the ventricles into either pulmonary or into systemic circulation. Finally, ventricular systole stops, and now you are in ventricular diastole. This is where you're going to get isovolumetric relaxation. So basically, the muscles are relaxing, the pressure has not popped open to fill the blood in these chambers. There's still blood in here, by the way. Then you end up with ventricular diastole late, where the pressure is much lower than the pressure up in the atria. So the pressure down in the ventricles causes the pressure difference. So the valves open up and blood is transferred from atria to ventricles. Again, 800 milliseconds. Auscultation areas for the heart. Best locations to hear heart sounds on the anterior wall. Each is named after the heart valve that can best be heard at that location. So you have 4 of them: the aortic semilunar valve, the pulmonary semilunar valve, the tricuspid area, the bicuspid area. Now, which way to listen, bell or diaphragm? The diaphragm, which is larger side, is ideal for detecting breathing, as well as normal heart rhythms. The bell, the smaller side, is better for detecting abnormal heart sounds and bruits, as well as bowel sounds. A cardiac exam should begin with the use of the diaphragm, followed by use of the bell. As you can see, here's the bell part, much smaller. Here is the diaphragm part, okay? Now, interestingly enough, they put in some of these a non-chill ring, so it doesn't come in contact with the skin and cause discomfort for the patient. The diaphragm hears the higher frequency sounds. The bell hears lower frequency sounds. And I want to give you all of this information to help you, especially for those of you that are in nursing and are pre-PA students. Okay? So here you see the position to place for the aortic valve, for the pulmonary valve. Notice the number of ribs. Where you're going to put this in is not on the rib itself, but on the space in between, called the intercostal space. The tricuspid valve down here, the mitral valve over here. Now, blood pressure. Let's talk about that for a few minutes. This is the force exerted by the blood on the blood vessel walls, a function of the pumping action of the blood and the resistance to blood flow. Blood flow through the circulatory pathways is a function of blood flowing from the pressure gradient, from high to low. In large elastic arteries, ones that are big, they stretch out when they have pulses, the blood pressure fluctuates between maximum and minimum corresponding to the cardiac cycle. So during ventricular systole, the ventricular ejection stretches the arterial wall and the arterial pressure reaches a peak. This is the systolic pressure. During ventricular diastole, the aortic semilunar valve closes. The elastic fibers, though, in the aortic wall recoil, and they force blood forward, and they help maintain sort of a less than the pulsatile manner. It kind of mutes the pulsatile, but maintains a certain pressure amount, leaving the area of the aorta. The aortic pressure declines to a minimum level called the diastolic pressure. Now, blood pressure in the aorta and other elastic arteries is pulsatile in nature, and it's not constant. Blood pressure is in smaller arteries and arterioles diminishes as the amount of elastic fibers decline. The blood flow in the capillary beds and veins travel under relatively low pressure with literally no fluctuation. A sphygmomanometer is a device to measure blood pressure. The measurement is in units. They're called millimeters of mercury, mmHg. Due to the pulsatile nature of the arterial pressure, both systolic and diastolic is measured. For example, 120 over 80. Now, how to read it? Systolic pressure, that would be the higher number, 120 millimeters of mercury. This is the force exerted by the left ventricle when it pumps blood into the aorta. Diastolic, though, is the low number. That's 80 millimeters of mercury. It's due to the resistance to blood flow in the arteries. Now, how do you do this? Again, you'll see several videos that will review this with you. Wrap the cuff of the sphygmomanometer around the arm. Position the stethoscope over the brachial artery distal to the cuff. Make sure the valve at the base of the hand bulb is closed. Squeeze the hand bulb to inflate the cuff. Now, inflating the cuff until the pressure is greater than the pressure in the brachial artery. Usually it's about 160 or more. Okay? The walls of the brachial artery are now fully compressed, preventing blood flow into the forearm. You can check this by listening for sounds using a stethoscope. By the way, I got a nice little, very brief video to hear what the sounds are like as you're making the adjustments and releasing the pressure, so you can tell when you start hearing noise, that's the high pressure. When you stop hearing noise, that's the lower pressure. So systole is when you start hearing noises. Diastole is when you stop hearing noises. Slowly deflate the cuff. While listening to the brachial artery with the stethoscope, the cuff can be deflated by slowly opening the valve at the base of the hand bulb. As the cuff pressure declines, cuff pressure becomes less than the peak arterial pressure, your first sound, thump. Blood flow is turbulent at this time. This is where we get into the sounds of Korotkov. These are sounds, the basic of the blood flow sounds, that healthcare providers observe while taking blood pressure with a sphygmomanometer over the brachial artery in the antecubital fossa. Okay? These sounds appear and disappear as the blood pressure cuff is inflated and deflated. As the cuff continues being deflated, blood flow is less turbulent. Blood flow sounds will stop. At that point of stoppage is the diastolic pressure. Here you see the individual, they've got their thumb, they put it over, notice that it's over the diaphragm, using the diaphragm in location for the brachial artery. The pressure recording device, you got the inflatable cuff. One hand is still pumping away, the other hand is holding the stethoscope against that artery. Now, here's the deal. As the pressure starts dropping, you still have the pressure greater than the pressure that fluxes through those arteries, so you still maintain no blood flow. When you start hearing the sound, the first sound, that's the high end, the systole. You will continue to hear ba-bump, 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 and when you stop hearing it, that's the diastole. Okay? You can see where this is diagrammed very nicely here. Now, we also have a measure called pulse pressure. That's the difference between systole and diastole. So PP, pulse pressure, is systolic pressure minus diastolic pressure. Now, there's another measure that's called mean arterial pressure. This is the average pressure that drives blood through the systemic circulation. No problem. MAP is critical for maintaining a steady blood flow from the heart to the capillaries. It is equal to the diastolic pressure plus 1/3 of the pulse pressure. So MAP is equal to diastolic plus 1/3 pulse pressure. Remember, pulse pressure is systolic minus diastolic. So if I said 120 over 80, I'd have a difference, a PP of 40. If I said that my diastolic was 80, I'd have to take 1/3 of that 40, add it in, and that's my mean arterial pressure. Measuring the pulse rate. As the left ventricular pumps blood to the systemic circulation. Okay, so it's the left ventricle. The elastic arteries expand and recoil at a frequency that corresponds to the heartbeat. So a pulse is the rhythmic expansion and recoil of the arteries. The pulse can be measured at various sites in the body. Now, radial artery is the most common, anterior surface of the wrist. You have also the femoral artery, where the femoral triangle is. the popliteal artery, posterior to the knee, the carotid artery, superior region of the neck, and then the temporal artery on the side of the head. Okay? The most common is the radial artery, but there are some of these others. For example, what happens if you had somebody who had no arms? How would you measure the pressure? How would you measure the pulse, I'm saying? Well, if they had legs, posterior to the knee, the femoral artery, okay? But you could also do superior region of the neck or side of the head. Have to be aware of these different sites, okay? Now, this is where we were going to do an exercise, and I do not encourage anybody doing this alone, first off. If we were to do it in the lab, the exercises I would encourage you to do, you do not do alone. You do them with someone else, but you also do not do them if you are ill. If you're dealing with a cold, a flu, an injury, you get one of your partners to do it. But in this case, what it was basically saying is, take your pulse, take your blood pressure, listen to the heart. Then do some exercise. Notice the difference before, afterwards, and then in a post-exercise period, say about 5 minutes or so. But I do not encourage anyone to do the exercises alone. I'm going to be very straightforward on that, because if you have no one to monitor you, you pass out, you fall forward. I don't want anybody to hurt their, have a head injury or anything else. Here's the basics. I want you to review the blood vessel anatomy and slides, as well as the gross anatomical arteries and veins. Get to know those tunics. Get to know the difference in one and the other for the lumen size, things like that. Any micrographs you'll be able to see either in this PowerPoint or in your text in the lab exercise. Review the cardiovascular physiology. Now, if you don't have a stethoscope and you don't have a means to do heart rate, blood pressure, pulse, no problem. View those videos. They will explain some of these points to you. Okay? You do not have to do in any way, shape, or form the effects of exercise on blood pressure or pulse rate. You do have 2 worksheets to get completed, 413 to 416 and then 431. Turn in the worksheets by the end of this week, Friday at 5 p.m. Okay? It's not submit them to me, it's upload them at the Blackboard site. And I hope you have a great day. Don't forget to view the lab videos. That's extremely important. Have a great day.